Hi all, let's continue with disorders of white cells. Uh, the objectives of today's lecture is to know the types of non-Hodgkin's lymphoma and try to understand the pathology of each of them. So before jumping straight into non-Hodgkin lymphomas, it is kind of important to know what is the structure of a lymph node and where all the cells are distributed. Okay, so this is a schematic diagram. If you see these things, these are the germinal centers. Corresponding germinal center on the on histopathology image is this one. And around the germinal center we have mantle zone and marginal zone. And this area is called cortex or cortical area. And just next to the cortical area, this blue area is paracortical area. So this cortical area is predominantly made of B cells, B lymphocytes. This area, paracortical area, is mostly made of T cells. And then the medullary area or medullary sinus area. There you can see macrophages, plasma cells, etc. So in histopathology, this is the germinal center, mantle zone, marginal zone. This is the cortex, paracortical area, medullary area. Now we'll jump straight into peripheral B cell neoplasms. We have already gone through precursor B and T cell neoplasm, basically ALL, acute lymphoid leukemia. In peripheral B cell neoplasms, we'll go through some of the most important entities, and it can be classified into aggressive forms and indolent forms, and probably a better morphological way of classifying would be small cell, intermediate and large cell lymphomas. Okay, first one we are going to look at is CLL. CLL is probably the most common lymphoma in the Western world. Mostly CLL patient will present as many times they will have no symptoms, or sometimes some weakness, weight loss, etc. And only on peripheral blood examination you will find some changes, that is increased WBC count. Some of them have lymphadenopathy, hepatosplenomegaly. This is a presentation. Yeah, forgive my poor handwriting, but the idea is to convey the concept here. It's called chronic lymphocytic leukemia, small cell lymphoma, because of a reason. Like as we saw, it can spread. It can spread in the peripheral blood, and it can be there in the lymph node also. So it is called CLL bar SLL. To call something as CLL, you need an absolute lymphocyte count of at least 5,000 in the peripheral blood. Usually presence in old people with a male predisposition, I think 2:1. The problematic cell in CLL is either a naive B cell or a post-germinal center memory B cell. Like as we saw earlier in the lymph node, A naive B cell, like as you have studied already, like B cells will be coming through afferent vessels like this, and when they're exposed to the B cells within the germinal centers are the naive B cells. When they're exposed to an antigen, they will become post germinal center memory B cell, like over here. So all the cells in CLL are arising from here or slight or just outside the germinal center. Yeah, and these are the pathogenesis of CLL. Includes increase in NF kappa B, increase Mike and Burton tyrosine kinase BTK. So you can see most of the lymphoid neoplasms having these alternations. Clinical features have already gone through. Mostly it may be more asymptomatic, and on investigations, peripheral blood shows smudge cells and increased lymphoid cells. Basically mature lymphoid cells. They are also called soccer ball. The nucleus is called soccer ball nuclei, or having a soccer ball pattern. And on a lymph node biopsy, there is a diffuse effacement of lymph node. Diffuse effacement means usually the lymph node has this nodular structure with periphery of the lymph node having follicles and center having less follicles, like that. So that distinction is lost. It's basically a diffuse infiltration of monomorphic cells. Usually lymph node is composed of polymorphous cells, different types of cells, and here it is mostly monomorphous cells, and they are small round lymphocytes. See, this is a diffuse effacement of lymph node by small lymphocytes. But these are the classical small lymphocytes of CLL. This is the nucleus. The small dot here is a nucleoli. The chromatin, you call it soccer ball pattern because if you see closely, doesn't these cells look like footballs? I don't like anybody calling football soccer, but still people who write these textbooks are from USA. They call it soccer. Fine, whatever. It's football pattern or what, soccer ball pattern. And this is the cytoplasm of the cell. And most cells are small lymphocytes here, but there are a few large cells, a pro lymphocyte. These are called pro lymphocyte. Okay, as the number of pro lymphocytes increases, the prognosis in CLL worsens. Okay. This is a peripheral blood picture of CLL. RBCs, platelets, and these are lymphocytes. But these are not our normal regular lymphocytes. They are mature lymphocytes for sure. They are not like blasts, big cells with open nuclei. They are smaller cells with more or less closed chromatin. This is cytoplasms. This is the nucleus, and here also if you see carefully you can see that soccer ball kind of pattern. And since these are very easily destroyed when peripheral blood is made, the nuclear material may get smudged or like destroyed and spread. So these are called smudge cells. Basically these cells when they are spread becomes like this. Very classical. Okay, now we go to the next small cell lymphoma. This is follicular lymphoma. Now follicular lymphoma arises from B cells within the follicles. Clinically they may present as with generalized lymphadenopathy, and it's an indolent lymphoma. Although there is no treatment as such, survival is about 8 years. It's an indolent means slowly progressing. Occurs usually in middle age with equal male to female ratio. Pathogenesis. Coming to pathogenesis of follicular lymphoma, most important thing here is BCL2. BCL2 is upregulated in follicular lymphoma. BCL2, as we have seen, comes in apoptosis. So when BCL2 is activated, cells do not go into apoptosis. Okay, in fact, BCL2 derives its name from follicular lymphoma only. BCL means B cell lymphoma 2 type 2. There are BCL1 and 2 types of proteins. Okay, so and there is translocation 14-18. We'll come to that later. Investigations. Mostly peripheral blood will not show anything, but lymph node biopsy will show usually a nodular pattern, sometimes diffuse. This is a nodular pattern. The difference between follicular lymphoma and a reactive lymph node would be absence of germinal center in a follicular lymphoma. The follicles are more or less of same size in follicular lymphoma, and they'll be infiltrating right into the medulla and may even infiltrate outside the capsule, and they're very dark. Then the follicles will contain centrocytes, which are these small cleaved cells, and centroblasts, slightly larger cells. Immunohistochemistry IHC will be BCL2 positive. Follicular lymphoma can get converted into a DLBCL, diffuse large B cell lymphoma, which is very aggressive compared to follicular lymphoma. So see that these are the follicles of follicular lymphoma. You can see this variation size is much less than what occurs in a reactive lymph node, and they are much closer, and clear-cut germinal center differentiation and all is not there. And higher power, you can see these are the centrocytes. These are the cleaved cell. This is the cleave of the cell. Okay, and these are larger cells called centroblasts. Again, the number of centroblasts decides the aggressiveness of follicular lymphoma. More centroblasts, worse prognosis. This is the immunohistochemistry of lymph node. This is a reactive lymph node. You can see BCL2 is positive around the germinal center. These brown dots are positive cells, nuclear positivity. Mantle zone basically. But in follicular lymphoma, it's almost a reversal of pattern. All cells within the germinal center are BCL2 positive. So there is no apoptosis happening in the germinal center. And that's how follicles become large and multiply. Next is diffuse large B cell lymphoma. The name itself explains what exactly it is. It's very aggressive. It is the most aggressive B cell lymphoma. It is pretty common, probably the most common lymphoma out there, and more common in males. There are many types of DLBCL. We don't have to go into that, but all you have to know is there are mutations in BCL6 and MYC. Clinical features include a rapidly enlarging lymph node or an extranodal site. Extranodal site can be anywhere, GIT, skin, bone, anywhere. Okay. Or DLBCL can arise from other B cell lymphomas like SLL, follicular lymphoma, etc. And lymph node biopsy shows large lymphoid cells, weird looking pleomorphic cells, and the diffuse effacement of lymph node, and it can infiltrate into surrounding areas. It's almost like a carcinoma. Can confuse a DLBCL with a carcinoma. You almost always need an IHC to prove it. Yeah, these are the tumor cells. You can see pleomorphism. Tumor cells are of various sizes and shapes. This is the nucleus. This is a nucleoli. So it's a vesicular nucleus, vesicular or open nucleus. You can see chromatin is less dense here, and these are nucleoli, prominent nucleoli. Almost looks like a melanoma here. Yeah, this is a cytoplasm, the surrounding area. This cell, you can see the cytoplasm here. Cells are very pretty demarcated. This is not the cell membrane. The outer one is the cell membrane. Okay. Burkitts. Burkitt lymphoma is probably the fastest growing lymphoma out there. It is of different types. An African or endemic type. It is related to EBV infections. And clinically, this is a classical presentation. It affects the mandible, presence as a mass in the mandible, and sporadic Burkitt's presence as a ileocecal mass usually, or peritoneal mass like this. Third category is HIV-associated Burkitts. In pathogenesis, most of the Burkitts are due to translocation of 8 to 14 or MYC-IGH, and EBV is often considered to be an etiological factor. And in lymph node biopsies, there is diffuse effacement of lymph node, intermediate size cells like we saw earlier. SLL, follicular lymphoma, are small cells, and diffuse DLBCL is large cell. Here it is an intermediate cell lymphoma. Most important thing is there are a lot of mitosis. It's a fast growing tumor, and nuclear debris are produced because of mitosis, and these debris are eaten up by macrophages, which are lighter stained cells in the lymph node. And because of these macrophages, it gives a starry sky appearance. Like this background is, if you consider this background as sky, and the macrophages will give a starry sky appearance. Yeah. Almost monomorphous cells. They look same. These are the tumor cells. These are mitosis. This dark irregular nucleus, they are undergoing mitosis. This is a macrophage. They are having lighter cytoplasm, so they look like stars in a dark background sky. Coming to mantle cell lymphoma. Again, it's a small cell lymphoma, pretty uncommon. Affects old people, males more than females. In pathogenesis, translocation of 11 to 14 is the most important one. Clinically, again, presents as lymphadenopathy, splenomegaly, and it can even affect the gut. It's moderately aggressive. Mantle cell, again, does not have any treatment, not curable. Survival is around 6 years. It can present as nodular. You can see nodules, but the difference is, since it's a mantle cell arising from the mantle zone, the mantle zone is increased and germinal center is almost atrophic, small, mainly composed of small cleaved cells, just like follicular lymphoma, and very rarely, not exactly very rarely, so 20 to 40% of times they do come out in peripheral blood, present as leukemia, just like CLL. So it is a differential for CLL. See, this is a mantle zone cells increasing, the very thick mantle zone and very atrophic germinal center. Cells are mostly monomorphous, small round cells, some are cleaved. There are a few large cells almost resembling pro-lymphocytes, like in SLL. Yeah. See, germinal center has a dark zone, light zone. Dark zone is due to centroblasts, the larger cells. Light zone is due to centrocytes. So our follicular lymphoma, NLPHL will come to it, is a type of Hodgkin, AITL, angioimmunoblastic T cell lymphoma, will come to all that. So basically follicular lymphoma arises from follicle. Is a naive B cell in the mantle cell zone. This is mantle cell lymphoma, and in from marginal zone lymphoma, marginal cell lymphoma. Coming to marginal zone lymphoma, again presence as, this marginal zone lymphoma is a recent addition. Actually earlier like we didn't know, like most of it presented as extranodal lymphomas. They were called maltomas, GIT and all, and the lymph node ones were called marginal zone, but nowadays it all comes under marginal zone lymphoma. So it can affect lymph nodes, spleen and extranodal tissues. Coming to pathogenesis, there is this is a lymphoma associated with chronic inflammation. So like autoimmune diseases like Hashimoto's thyroiditis cause marginal zone lymphoma of thyroid. Sjogren's causes lymphoma of salivary gland, and in stomach, H. pylori related inflammation can cause marginal zone lymphoma. But again, this is a very beautiful lymphoma, because it is it shows a transformation from a polyclonal lymphoid infiltrate to a monoclonal infiltrate, from polyclonal continuous activation of lymphocyte, finally leading to a mutation mutation in one of the genes and causing an increase in NF-kappa B and causing hairy cell leukemia. It's again a B-cell leukemia, which gets its name from the shape of the cell itself. Occurs in old males. It's due to BRAF mutations in the serine threonine kinase pathway. In peripheral blood, there are classically hairy cells. It's an indolent leukemia. These are the classic hairy cells. This is phase contrast microscopy. These are RBCs. These are our lymphocytes with hair-like projections. These are the stain smears. The projections are not very obvious here, but they are still there if you look carefully. Now that we've gone through peripheral B cell neoplasms, we'll shift our attention to peripheral T and NK cell neoplasms. Like peripheral T cell neoplasms are generally more aggressive and have worse prognosis than even DLBCL. So T cell neoplasms are worse than B cell. The most common ones are, you can say, PTCL. In general, peripheral T cell neoplasms are pretty uncommon compared to B cell. Like it is around 10% of lymphomas only. Now, out of the peripheral T cell lymphomas, most are like put in a wastebasket category, like PTCL, peripheral T cell lymphoma, unspecified, where you see lot of mature T cells and in a mature T cells in a background of reactive eosinophils and macrophages. Cells are pretty pleomorphic. These reactive cells are due to cytokines produced by the T cells itself. Coming to anaplastic, second type is anaplastic large cell lymphoma, or there are two types, ALK positive, ALK negative. The classical cells are hallmark cells. The hallmark cells are large cells. They look almost like RS cells. So that way, ALCL is a differential for Hodgkin lymphoma also. Third one is adult T cell leukemia lymphoma. It can involve skin and other extranodal areas. And blood shows even peripheral blood can show a clover leaf or flower type cell. Pretty bad prognosis. It's associated with HTLV. Yeah, this is more important. Mycosis Fungodus and Sézary syndrome. Mycosis Fungodus is a CD4 plus T helper cell lymphoma. It is very dermatotropic. It affects skin, and like in Sézary syndrome, there is erythroderma or skin lesions along with leukemia. These lymphoma cells spill into blood, and these cells are called cerebriform. The called Sézary cells, they have a cerebriform, brain-like nuclei. In fact, mycosis has a few stages. Indolent plaque stage and a tumor stage. Go through it. Large granular lymphocytic leukemia. Again, T NK cell It can cause autoimmune phenomenon and cause cytopenias. Now, extranodal NK T cell lymphoma, EBV associated, and it's aggressive. And again, peripheral T cell lymphomas are not very important, but you have to know these categories exist. This is PTCL unspecified, as we saw earlier. You can see these are all tumor cells. Background. Tumor cells are pretty pleomorphic, but the reactive background cells are not much here. Some macrophages are there. Looks like EOS, not sure. They're not very clear here. But like in a biopsy, you'll see pretty pleomorphic, this kind of vesicular cells with conspicuous nucleoli. Anaplastic large cell lymphoma, as the name suggests, they are very large cells and pretty anaplastic, bizarre kind of cells. And many of them, like these are, if you look at this, they have this embryonal kind of shape. It's called embryoid nuclei. It almost looks like a human embryo or horseshoe like. And this is immunohistochemistry for ALK. ALK is positive in the cytoplasm. Okay, now we'll shift our attention to a very, you can say, different kind of lymphoid neoplasms. Some people even classify it separately. Plasma cell neoplasms. They are neoplasms of mature plasma cells. They are B cell neoplasms. The characteristic feature is production of a monoclonal immunoglobulin. This immunoglobulin spike, which is seen in electrophoresis, is called M component or M protein spike. M because related to multiple myeloma. There is an increase in production of light chains associated with this, which is excreted in the urine. Since they are very small, kidney cannot filter them. They are called Benz-Jones proteins. There are certain terms associated with plasma cell neoplasms. First one is multiple myeloma. We'll look into multiple myeloma here itself. Plasmacytoma basically means a solitary lesion of plasma cells. Very like compared to multiple myeloma, it's rare. Waldenstrom's macroglobulinemia, it's associated with lymphoplasmacytic lymphoma. There is hyperviscosity because of there is hyperviscosity of the blood and there is hyperviscosity symptoms. You can go through Waldenstrom's on your own. There is heavy chain disease. Instead of light chain, heavy chains can be produced monoclonally. And MGUS, monoclonal gammopathy of unknown significance. Coming to the most important of these, multiple myeloma. You have to think of CRAB for multiple myeloma. CRAB are the clinical features and of course the diagnostic criteria also. There is it causes hypercalcemia, renal dysfunction, anemia, bony lesions. They are called punched out bony lesions measuring 1 to 4 centimeters. Hypercalcemia because there are bony lesions and calcium is released. Anemia because of bone marrow infiltration and renal dysfunction. Renal dysfunction because of plasma cell infiltration. or this due to deposition of proteins released by the tumor cells. Now, in the pathogenesis, like there are many factors involved: IgH, P53 mutation, MYC, NF-kappa B, increase in NF-kappa B. These are all things which we have seen in other lymphomas. Along with that, there is an increase in interleukin 6, which promotes the growth of these plasma cells. In investigations, electrophoresis is a screening test. Shows an M spike, M protein spike, basically an immunoglobulin Ig light chain. In peripheral blood, there can be rouleau formation. The smear may appear pretty blue because of paraproteinemia. Plasma cells may come in blood, but it is very rare. When it comes to blood, it's called plasma cell leukemia. In bone marrow, there will be increase in plasma cells. You may see plasma blasts. And there are different cells called flame cells, moat cells, Russell bodies, and like inclusion bodies called Russell bodies, Dusha bodies, etc. These are all basically due to inclusion bodies, or like I can say accumulation of immunoglobulins within the plasma cells. It's a classical X-ray in a case of multiple myeloma. There are multiple sharply punched out lesions of the skull. You can see these darker areas with low bone density. It is one, and this is a picture of serum electrophoresis in a case of multiple myeloma. It's a normal serum. This is serum protein. Here you can see a band. Here you don't see a band. And if you compare where the band is coming from, you can see it is IgG and kappa light chain. And there is a reduction of IgA, M and lambda, and increase in G and kappa. This is M band. This is called M band. Bone marrow aspirate. These are the inclusions we were talking about. These are Russell bodies, and if there are inclusions within the nucleus, they are called Dusha bodies. And this can be called a moat cell. This is a moat cell. Multiple Russell bodies within a cell. That's it, I guess. We'll stop for today. As we'll continue with the rest of the topics tomorrow. Okay, thank you.